Welcome to this seminar. Thank you for joining us today. My name is Vikram Patel. I'm a psychiatrist. I'm a Paul Farmer Professor of Global Health and the Chair of the Department of Global Health and Social Medicine. And it is my pleasure to welcome you today to this EdGHI's Global Health Research and Innovation Speaker Series. I'm delighted to welcome my dear friend and colleague, Professor Joe Gone, to present today at these series. These are monthly series which are designed to showcase the latest advancements in global health research with the goal of fostering dialogue and elevating innovative solutions to advance global health solutions. And it's particularly important for me to point out that when we talk about global health, we're also talking about domestic health equity issues, and I'm sure you'll understand why Joe's remarks today are extremely relevant to conversations around global health. I also welcome you to continue to join these talks for more timely discussions on critical insights and innovative solutions arising from the field from very diverse locations around the world, including here in the United States. Professor Gone, let me introduce him now. Professor Gone will be presenting Rethinking American Indian Mental Health Services, Exploration in Alter-Native Psy-ence, with an interesting play on the word science, as you'll see in a moment when Joe will show his slide. Just a few notes. The session is being recorded, and so I hope you are all okay with that. Joe will have time to take some questions at the end of his remarks. Please use the Q&A box at the bottom of your screen to post your questions, and we'll try and do our very best to answer as many questions as possible. With that, let me introduce our speaker. Professor Joseph Gone is the Professor of Anthropology and of Global Health and Social Medicine at Harvard University, where he also serves as the Faculty Director of Harvard University's Native American Program. He's an international expert in the psychology and mental health of American Indians and other indigenous peoples. Dr. Gone has collaborated with tribal communities for 30 years to critique conventional mental health services and to harness traditional culture and spirituality for advancing the well-being of indigenous peoples. As a clinician and as a community psychologist and action researcher, Professor Gone has published over 100 scientific articles and achieved recognition in his fields through more than 25 fellowships and career awards, including a Guggenheim Fellowship. Dr. Gone is a graduate of Harvard College and the University of Illinois, and has also trained at Dartmouth College and at the McLean Hospital of Harvard Medical School. He taught at the University of Michigan in Ann Arbor for 16 years, where he directed their Native American Studies program prior to joining our faculty at Harvard. He's an enrolled member of the Ni Grosventre tribal nation of Montana. He also served as the Chief Administrative Officer for the Fort Belknap Indian Reservation. He's currently a fellow of the Association for Psychological Science and of 7 divisions of the American Psychological Association. In 2023, he received a gold medal award for impact in psychology from the American Psychological Foundation. He is an elected member of the U.S. National Academy of Medicine. With that, it's my great honor to present Professor Joe Gone.
Well, thanks, Vikram. I really appreciate that. And thanks to the folks at the Harvard Global Health Institute for inviting me to speak with you today. I'm just going to share my slides here so that you can see what I have in mind for us to review together. Okay, so I'm going to be speaking with you in the next 25 minutes or so about rethinking American Indian mental health services, explorations in Alter-Native Psy-ence. And just by way of brief background, since time is limited today, we have experienced and encountered and have documented for many decades certain mental health inequities within American Indian communities throughout the United States, which is to say that we have epidemic levels of distress in too many of our communities. That tends to include a pretty high prevalence of trauma and substance abuse. And yet the mental health services that are on offer to try to ameliorate these problems are pretty deeply underfunded and have been since they were developed and cultivated back in the early part of the 20th century. And that leaves many of our communities with a large unmet mental health need. So if we try to start to begin to imagine solutions to this inequity, we could imagine, straightforward based on that portrait, that the answer is pretty self-evident. On the one hand, we have pronounced mental health problems. On the other hand, we have underfunded mental health services. So the answer is pretty obviously, let's expand the mental health services we offer, right? Let's make sure that there are adequate funding, that we hire more providers, that the providers are able to see more patients, and therefore that we can begin to address these disparities or inequities in ways that could begin to address the problem. Well, early on in my career, I had an opportunity to conduct research that challenged that very simple solution that presents itself in response to this framing of the problem. In my very first research project after I left my doctoral program, I began to explore the intersections of American Indian culture, coloniality, and distress back home on my own home reservation, the Fort Belknap Indian Reservation, which lies in north central Montana. There we have Aani people and Nakota people, and I have ancestry from both, although I'm a tribal member of the Aani Grovant tribal nation. There, during this project, I just aspired to really bracket and hold at bay all that I had been trained and taught about clinical practice in mental health, to instead proceed in more anthropological fashion, using open-ended and discovery-oriented inquiry to try to ascertain and determine what are the local construals from people at home of the relationships and intersections between culture, drinking, depression, and so on. In other words, to try to understand how psychological and psychiatric distress are made sense of by people at home and on the ground. Well, I talked during this project with a number of individuals, members of an extended family, leaders on the reservation, administrators of health services. But I ended up focusing in this work on a case study with one particular individual I conducted an interview with, who decided in our work together to go by his Indian name, which translates as Traveling Thunder. So I conducted an interview with Traveling Thunder, and Traveling Thunder offered what we in medical anthropology would refer to as an explanatory model for mental health problems at home on the reservation. An explanatory model is basically a conceptualization of the origins and causes and consequences and treatments, et cetera, of particular kinds of medical problems that might arise. And so this explanatory model, as I'll reveal momentarily, really depended on Traveling Thunder's elaboration of 4 historical eras in the history of reservation life. So let's look into that for a little bit here. The first historical era that Traveling Thunder talked about sounded like paradise, as he described it. This was an era defined by pre-colonial existence before Europeans arrived in our neck of the woods. And here's what he had to say about this first era. Quote, "See, there was no alcohol in this continent 500 years ago. There was no drugs. There was no problems, no domestic problems, no social problems. Everything was good because everybody lived according to custom and teachings. And there was no jails, no hospitals, there was no prisons, no insane asylums. There was none of that stuff because everybody lived according to a strict custom." And so we see here, as Traveling Thunder describes this kind of paradise that existed before the arrival of Europeans, that there was a kind of perfect harmony and balance that he could use to characterize Indigenous life at this time, owing, as he said repeatedly, to strict observation of custom teachings. Okay, so that's what kept things in order. But of course that changed, and so Traveling Thunder did talk about a second era of history that mattered a lot in terms of the origins of mental health concerns in our community, an era marked by conquest in the wake of colonial contact by European arrival. And here's what he had to say about that. Quote, "But when the white man came, they forced the Indian people to get rid of their way, their religious spiritual beliefs. They forced them to trade their economy, which was based on the barter system and on living off the land, the wildlife, fish, and herbal medicines. Then they turned around and forced their culture on them, their religion, their beliefs, their foreign ways onto them by taking all the young people out of the homes and putting them away in boarding schools and forcing the white man's teaching on them. It's genocide." And of course, by boarding schools, he's not talking about elite private prep schools. He's talking about government-run industrial schools, which were designed overtly to kill the Indian, save the man, as it went. Well, here, Traveling Thunder in this second era is really pointing to the annihilation of custom, the eradication, the subjugation of teachings and customs that kept things in order prior to the arrival of Europeans. And this is, he says, marks this era of colonial contact. Well, you can imagine there would be consequences of this period of conquest. And so he described this third historical era, one characterized by loss, which is to say the effects of colonialism, the post-colonial consequences of this sort of interaction. Here's what he had to say, quote, "If you don't know your own true oral history, your true oral traditions and customs and where you come from and what's supposed to be important to you, well, you're going to feel empty. You're going to feel like you don't belong because we don't fit in with the white man system. We never did and we never will. It basically boils down to pride. If people ain't proud of who they are, where they come from, and what they're doing, then they're going to be doing these things, alcohol, drugs. And once you're into alcohol and drugs, you're going to probably get into depression. You're going to not feel worthy of being a human being, and you're going to want to kill yourself." So here we see the after effects of this period of colonial subjugation that Traveling Thunder is describing, in which he really points out that what we might call anomie, a term that means no law, but in psychology, it means a loss of purpose, belonging, identity, and a way of life orientation to how to go through your own existence, how anomie leads to pathology. And interestingly here, as he talked about feeling empty, feeling like you don't belong, and all the bad things that can follow from that, he really pointed to what he repeatedly referred to throughout our interview together as the white man system, as pathogenic, as the cause of this pathology as it unfolded and manifested in these various ways. Well, fortunately, according to Traveling Thunder, we weren't stuck in this era of loss. There was a fourth era that he described, an era characterized by revitalization, in which a remedy of sorts for coloniality is made manifest. And this era happened, beginning in maybe the late 1960s, early 1970s, with the rise of the Red Power movement or the American Indian movement. Here's what he had to say about this era of revitalization. Quote, "After we looked around and realized that we left something behind, we started going back to the hills to fast. We started going to the sweat lodges to pray and to sweat. We started going to the elders to learn. We never was happy living like a white man. I would give the credit to the Creator and to the spirit world for pitying the people to allow us to get our sacred traditions back. To me, what that ceremony does is you're calling on the Creator, the spirit world, for life or for good health or for a good, clean mind, an alcohol and drug-free mind. Or you're calling on the spirit world for guidance or for survival even survival." And so we see in this fourth era of revitalization, the era in which we currently live, Traveling Thunder underscores the kind of return to sacred custom, the custom and teachings that kept things in balance and harmony prior to the arrival of Europeans, as a potential remedy for having a good, clean mind, an alcohol and drug-free mind. And so now, just to back up and talk about Traveling Thunder's explanatory model and point out a few things about it. First of all, as I've just recounted to you, there was a pretty clear pathological process that Traveling Thunder identified in our interview. He talked about cultural repression and subjugation to the white man system as leading to a loss of identity and belonging, or anomie, which he then said could lead to substance abuse, which in turn could lead to depression and feelings of worthlessness and ultimately suicide. So in his very words, I showed you how he linked these things and ordered these things in a process of pathology. Interestingly, when Traveling Thunder talked about mental health problems in our community in the ways that I just described, he offered very little elaboration of personal distress. He didn't talk too much about individuals, this person, that person, and he offered a relatively non-biological and even non-psychological account. He didn't talk about the things that mental health professionals, particularly in the 1990s, would have talked about, which have to do with genetic predispositions and aberrant brain chemistry, maybe family dynamics early in childhood, maybe even defense mechanisms gone awry. He didn't talk at that level about any of that. It really wasn't all that individualist at all. Instead, Traveling Thunder, as you've heard, emphasized history, culture, and spirituality as accounting for the rise of mental health problems in our community. Moreover, Traveling Thunder was very clear about how and why these things arose. He talked about the pathogenic aspects of the so-called white man system, in which he very overtly identified colonization as the original foundational cause of native distress. And in doing so, he really emphasized systemic factors over intrapersonal factors. Again, not focused on the individual, not focused on what's going on inside an individual, but really about stuff that's going on out in the world in systems of subjugation. And in that respect, he wasn't focused on this person and that person, but on our shared community vulnerabilities that come from dominance by the white man system. Now, we have a very elaborated way to talk about this very kind of explanatory model that Traveling Thunder's offered. Today, zooming forward now, some 30 years, the language is historical trauma. That's the way Indigenous people, when it comes to mental health concerns in Indian country, talk about this legacy and this model and account for how psychological problems and social suffering arise. What's interesting is to bracket for a moment is we call it historical trauma today, but Traveling Thunder did not use the word trauma. That wasn't really in vogue, particularly in his part of the world or our neck of the woods on the reservation at that time. And he wasn't particularly psychologically attuned in his explanation. So he never used the word trauma. And yet, a lot of what he talked about is precisely what historical trauma today is meant to capture. Colonial subjugation as being the original mechanism and mediated through enemy and problems that follow from that. Well, if you're hearing all this, taking it in, getting a sense for what Traveling Thunder was telling me, as I did, you might wonder, well, then what's the relevance of like psychosocial interventions, mental health services, counseling and therapy and the like? And so I said to Traveling Thunder at this moment, I said, okay, I think I follow you. I've got what you're saying. But under what conditions would you take a loved one who was going through a really tough time down to the Indian Health Service Behavioral Health Clinic at Fort Belknap Agency, the government health clinic, and get them some support, some counseling, some therapy? Under what conditions would you do that? And he grew quiet in response to that. And I think the pause probably only was 10 seconds, but it felt a lot longer. And when he resumed speaking, it was quite sober. And here's what he had to say about that option. Quote, I guess it's like a war, but they're not using bullets anymore. They want to wipe us out, and therefore the Indian problem will be gone forever, but they're using a more shrewder way than the old style of bullets. If you look at the big picture, you look at your past, your history, where you come from, and you look at your future, where the white man's leading you, I guess you could make a choice. Where do I want to end up? And I guess a lot of people want to end up looking good to the white man. Then it'd be a good thing to do. Go to the white psychiatrist in the Indian Health Service and say, well, go ahead and rid me of my history, my past, and brainwash me forever so I can be like a white man. I guess that'd be a choice each individual will have to make. Well, obviously, Traveling Thunder was very clear that this was not the choice that he himself would want to make. But in describing mental health services in this way, he is very explicitly and overtly describing mental health treatment as a form of cross-cultural encounter for many of our people. That, it's definitely foreign and it's not our way, it's part of the white man system. But he goes on to point out that mental health services have an ideological function, that he's identifying or suggesting that consulting quote unquote white psychiatrists in the Indian Health Service is an invitation to a form of implicit Western cultural proselytization. And I use this term proselytization somewhat deliberately. Proselytization refers really to missionary work, to Christianizing Indian people, for example, which was a government policy for a long time in the United States. The idea was we were savages and we needed to be civilized, and bringing Christianity to us was a way to civilize us. So proselytization was what things were all about. But it's quite interesting to attend to what Traveling Thunder had to say here about psychiatry and mental health services, to start to imagine and entertain the idea that such services themselves may also be a form of proselytization, of missionary work, if you will, that has ideological dangers for Native people that are associated. And so I paused at the beginning by just simply allowing that we have inequities, and yet the services are not funded and resourced adequately, that maybe the expansion of mental health services suggests itself as a straightforward solution. But through this early research with Traveling Thunder, I realized it ain't that simple. We do have a problem of cultural difference, in which reservation communities, even today, and the origins of counseling and psychotherapy and mental health services come from really different and distinctive cultural enclaves, which is to say they have different cultural orientations, about cultural values, cultural logics that undergird them. And yet these practices that originated, a century and more ago, persist today in ways in which those distinctions and differences can still matter. And for Native peoples, for example, the ideas about cosmology, about how who the supreme being is, about how the sacred beings in the world animate the cosmos, about our right relationship with them, actually imprints or actually extends to shape how we think of cultural psychology or ethnopsychology among our own people in ways that, again, can look really different than the assumptions of the mental health professions. And so ultimately, it's just recognizing with this problem of cultural difference that the culture of the mental health clinic is not the culture of the Native community. Well, cultural difference is one thing. When you have cultural differences, you can often have a meeting of the minds. You can sit, you can negotiate, you can visit, you can try to understand each other, you can exchange understandings, and you can work out your cultural differences. But that's unfortunately not the main source of the problem here. The bigger problem is the problem of cultural dominance, which has been the long-standing assumption that the cultural differences in play are because Indian people are inferior and don't have actually sophisticated and interesting ways to make sense of and think about their worlds. So this problem of cultural dominance is what played out through colonial subjugation, which first and foremost, of course, was about repurposing land, stealing land, or buying land, or getting the land, however it would be possible. And then second of all, by containing a remnant population that now no longer has resources to support itself. And again, if you think about the boarding schools or the industrial schools in particular, that became a primary way that Native youth were imagined to be socializable into the broader American populace. But the idea was still one of cultural dominance. Kill the Indian, save the man. You've got to eradicate all that is culturally native or indigenous about these people to civilize them for modern life. Unfortunately, the power asymmetries that gave rise to and that took shape in this long period of colonial subjugation persist today. Native people are still subject to plenary power of the United States Congress to even terminate us, to sort of Congress to pass a law that says you no longer exist as a tribe, we no longer recognize you as a Native people, you're now just individuals, welcome to the United States. So there are all kinds of ways in which cultural difference could be a problem, but really it's cultural dominance that plays out in ways that are especially difficult to know how to remedy. All this gives rise to what I've called the post-colonial predicament of community mental health services for Native and Indigenous communities. And that predicament is basically this. On the one hand, we have pretty urgent community needs. Too many of us live in impoverished and high-risk settings on our reservations. This is associated with and leads to documented inequities in mental health status. And yet, on the other hand, the services that are on offer are often incongruent to actually remedy these problems in terms that we find acceptable. It's back to what Traveling Thunder said, which has to do with, consulting a psychiatrist is basically an invitation to brainwash me forever so I can be like a white man. And this incongruence of clinical services with meeting our needs when confronting distress is attested to by community anecdote, wherever you go, wherever I've gone, but of course by research evidence that more systematically assesses these attitudes. For example, in the Midwest reservation settings, there's been research where Native people were asked, in a time of great distress or trouble, who would you turn to? And to free list as many different and suggest all the different possibilities for who they could turn to. Mental health professionals don't even make the top 10. So the clinical services end up being incongruent for a swath of our population. That is the post-colonial predicament. I want to close then today by gesturing, summarizing briefly, an entire different alternative way that Native people then think about the mental health endeavor that sort of is based on the kind of explanatory model that Traveling Thunder offered, but that really anchors what I've come to call an alter-native science. So what is an alter-native science? Well, alternative, I think you get, it's alternative, but it's indigenous, so it's alternative. Science, I'm deliberately playing with PSY instead of SCI science. So Psy refers to the Psy disciplines, the disciplines of psychology, psychiatry, psychotherapy, psychoanalysis. These are really big cultural formations that come online starting a little over a century and a quarter ago now, in which there's medical professions and healthcare that is all about trying to manage, regulate, intervene, and support and assist people with managing their psychology, especially when things go wrong. And there's all kinds of knowledge and expertise that inform what this PSY science is and does. Now, there's often a movement within science to ground our knowledge and expertise and practice in empirical evidence and in scientific research, SCI scientific research. But the fact is that a lot of what we do in the Psy professions goes above and beyond what empirical research actually supports. In fact, there's no way to conduct enough studies to really ground every aspect of what happens in a counseling or therapeutic endeavor, for example, is grounded in empirical recommendations. So the knowledge of the sciences goes above and beyond, extends in front of what we know through empirical research. That's what science is meant to capture. There's an authority, there's a bunch of lore, there's a bunch of cultural stuff that is packaged as part of the professional expertise that we wield that goes beyond what we know scientifically. That's why it's called science. Okay, so on Alter-Native Psy-ence, I'm just trying to trace out in the work that I've done since this important research, what are the ways that Native people are talking about the mental health domain, and how does it differ from mainstream psychiatric expertise? And here I've just selected 4 domains quickly: distress, well-being, intervention, evaluation. These are domains that the mental health professions have a stake in, have a conceptualization of how to think about such things and so on, that in the work that I do in Indian country has come to be looking quite different. So when it comes to distress, there's very little interest in Indian country about mental disorders, about psychiatric conditions as described in the Diagnostic and Statistical Manual of Mental Disorders, in the classification promoted by psychiatry, but instead much greater interest in historical trauma as an explanation, account, and even a language for describing what's wrong in our communities, what has led to our suffering. And I've just unpacked Traveling Thunder, talked about how historical trauma really indexes that way of explaining these kinds of problems. So that you get a sense then historical trauma is what's of interest for accounting for distress rather than mental disorders. When it comes to well-being, this is a domain that the Psy professions don't necessarily delineate in any great detail. It's really about reducing symptoms and improving functioning. People don't really sketch out, well, here's what it means to live a good, healthy life so much. But what's really clear is that Native people are not so interested in one recognizable form of modern life and self, which would be described as neoliberal individualism. This is like in the middle classes of modern America, affluent middle classes, where you can think of people as independent or free agents navigating free markets in pursuit of happiness and success and money. That's not particularly what reservation Indian people value or care about. Rather, it's indigenous forms of self and personhood. I've written about this, so there's a lot more to say about it than I can now, but let's just say that in general, these forms of self and personhood are a lot more relational. They're a lot more about your connection to kin and family and place and the sacred domain that you are familiar with, etc. So well-being can take on a quite different cast. When it comes to intervention, Native communities are much less enamored, not particularly interested in what so-called empirically supported treatments. These are the latest, greatest counseling, medication approaches in the mental health professions that have been scientifically vetted to try to guarantee that they are likely to help people. And yet Native peoples just don't talk about these, don't ask for them, aren't excited about them when they're presented. Rather, there's more enthusiasm and interest in reclaimed traditional healing practices. So indigenous healing practices are the kind of thing that generate enthusiasm and interest, and figuring out how to harness those. Often what people will say is, we don't need the latest, greatest evidence-based practice. Our culture is our treatment. So we're preferring instead these kinds of reclaimed practices. Finally, in the domain of evaluation, which is a question of what works for whom to help people when they're suffering and distress. Again, Native communities, Native mental health professionals, Native PhDs, in fact, seem sometimes less enthused or interested in scientific outcome studies as a way of adjudicating how we know what works, and are increasingly invested and interested in what are described as indigenous ways of knowing. That is, epistemic practices that have a longer tradition within an Indian country. The primary differentiation I would make in this, drawing in broad brushstrokes for now, is that first-hand personal experience is probably the most authoritative way that Native peoples have traditionally invested authoritative knowledge. That I experienced it and therefore I know it. Hearing about some study long happened some other place and some other time by experts publishing in a journal carries minimal weight when it comes to this authoritative way of knowing that is preferred epistemically in some of our communities. So what I've tried to do here today has been to lay out for you an early career lesson in which I went home to my own reservation to try bracket all I've been taught as a mental health professional, and instead to investigate in open-ended, discovery-oriented fashion what explanatory models for mental health problems might arise in my own community. I've traced that out from this interview with Traveling Thunder, in which he talked about 4 historical epochs, leading to what I call the post-colonial predicament for community mental health in Indian country, which is to say, on the one hand, we have problems, on the other hand, the services that are on offer are often not really fitted or tailored to addressing that problem in a helpful way. And I'm suggesting then that postcolonial predicament defines and gives rise to an alter-native science, which is to say within our Indigenous communities, there are alternative ways of thinking about the domains that are relevant to the mental health endeavor relative to distress, relative to well-being, relative to intervention, relative to evaluation, that contrast and contest even mainstream knowledge in the psychiatric and psy professions more generally, and therefore are in need of some kind of translation, bridging, reconciliation, or rejection. And that's what I've come to learn over the course of my career about these matters. Now, I've had 25 minutes to share with you today about some what are actually pretty complex issues. So there's a lot more about all of this stuff I've talked about on my website. This is my last name is Gone, the English word gone. It was clipped from my great-grandfather's father, which was given to him as his surname when he started industrial school in 1891. His stepfather's name was Gone to War, so they just clipped it to Gone. We are the Gone family from Fort Belknap because of this. This is my website handle, and on my website, there's a whole page of all my publications and descriptions of my research and some of my talks that are recorded. Just want to make sure you have awareness of where to go for further follow-up on some of the issues I've raised here today. I'm just going to stop sharing my screen now and let us get back to some consideration of questions or comments based on what I've had to tell you. Thank you so much.
Thank you so much, Joe. So the questions, please use the Q&A box to post your questions. I can already see a couple, but let me take the privilege of being the moderator to actually kickstart the questions. Joe, I wanted you to speak to a little bit about the importance of place here. The American Indian or Native American community is incredibly heterogeneous and diverse. And in our previous conversations, you described, for example, where you live, whether it's on a reservation or whether it's in, as it were, integrated within urban America, may play a lot of role in influencing explanatory models. So could you speak to about the diversity of explanatory models? You presented a particular narrative from Traveling Thunder, but really, how frequently do people who self-identify as Native Americans embrace exactly that same explanatory model?
Yeah, thank you. Well, it's an empirical question for which we don't have an empirical answer. So that's to acknowledge up front that it's a little bit speculative and based on my experience, traveling across a lot of these different communities. The first thing is that really Traveling Thunder's outlook is one that we might refer to as kind of a traditional mindset or a traditionally oriented mindset. And on any reservation, there's a swath of our population that is of that sort. But there's also swaths of the population who are less traditionally minded, and for whom, going to see a counselor or therapist on the reservation would not be a problem at all. They could take to it like a duck to water. So there is, in fact, diversity around these explanatory models, these worldviews, these outlooks, these cultural orientations, no matter where you are, including on reservations themselves. Once you move out into an urban space or an off-reservation space, there's a lot of Native people who end up becoming perfectly culturally adaptive to mainstream society, in which case these dynamics may not play out in any meaningful way as you're meeting with them. On the other hand, our urban cities often have Native communities of Native people who continue to hang out together in Native centers. They go to Native clinics. In those clinics, they would be very familiar with some of these outlooks relative to this explanatory model. And in part, I think that's why we can account for the popularity of the term historical trauma, which only entered the psychological scientific literature for Indigenous peoples in the mid-1990s and has taken off. It's everywhere, every community. Most Native people who know about health and well-being from a Native vantage point understand, recognize, and probably believe in historical trauma, and will use that language. I think that's one indicator of how widespread this particular discourse and outlook is in Indian country.
So let me take a question. I'm going to reframe that question a bit because I had a very similar question, and I'm going to merge these. So one of our participants and I both want to ask you this one question. You are trained as in the biomedical tradition, and you now also work as an anthropologist. And we want to hear your thoughts about the possibility, the likelihood that it is really possible to integrate biomedical perspectives of mental health with those that come from the cultural context of Native Americans. Given how divergent it seems the epistemologies are of these, one focuses on the brain biology and the other one focuses on the social world in a very simplistic way. These are quite fundamentally different. how probable is it that you can actually imagine these being integrated? And relatedly, you mentioned the word spirit. To what extent, for example, the idea of the spirit actually is aligned with the idea of the mind that exists in biomedicine?
Yeah, right. It's a great question, and because the issues are so complex, I think the answer depends quite a lot on what particular specific domains we're talking about. I think there are ways in which um, integration is possible when there's not like direct contradiction, direct repudiation of competing or just say diverse understandings or ways of making sense of things. And in which case they might be able to be integrated in some really useful ways. And it depends on where you see the differences and where you see the similarities. So for example, I did ask Traveling Thunder at one point, well, what would you do instead? If the white psychiatrists aren't going to do it for you, what is the thing you would do with this loved one who needed help pretty desperately? He said you'd put up a ceremony, call on the spirits, pray sincerely to the grandfather spirits. And, if you're really, really sincere, he said, they say that, 50% of the time you'll get help. So he understood prayer, which we can say is a form of communication, a form of talking. When I've been in sweat lodge ceremonies, which is one therapeutic inherently, as well as other things, people talk and they talk about their suffering and their problems, but they don't necessarily talk to other people, or other human beings aren't necessarily the main, person they're talking to. They're talking to, spirit beings in that religious ceremony. So talk is common to both therapy and to prayer, but it's obviously a different kind of talk. And so is there ways to integrate that? It sort of depends on what you're emphasizing here. I think there are some things where it's really hard to integrate because they directly contradict. And I also think there are other things where the integration looks more like, I'm going to tell this story in this modality, and you could also tell a story in another modality, and the modalities stand on their own irrespective. So I could tell a psychological account of why sweat lodges might make a difference for remedying addiction for Native people. That has to do with anomie and remedying anomie and having a sense of belonging and purpose restored for living a good life. But that's not the story that most Native people who participate in sweat lodge ceremonies would do. They would probably tell a religious story, which is one about, I prayed to the spirits and the spirits helped me. Both of those things can be true, and they aren't necessarily contradictory, even though they would be different preferred ways of accounting or explaining these things. So that's another way of thinking about how integration might work.
Thank you. There's a great question that follows on nicely from your response there, and it is this: in all your travels and explorations, can you share with us an example of a program that has successfully been able either to integrate or to provide culturally appropriate mental health services, with some success to Native American communities?
Yeah. Well, okay, so this does depend a bit upon how you want to define success and what criteria you have for evaluating that success, right? So let's just say that there have been very few randomized controlled trials of any treatment with any Native population, as in when it comes to the mental health domain, like less than a dozen, which is to say that they've not been replicated. They don't typically have large sample size. So if your criteria for adjudicating what is effective or successful is an RCT, there's not going to be an answer for that. However, Native peoples offer plentiful answers about, what's helpful and what works and what's useful. And certainly it's the case that everywhere you go in Indian country, there have been Native people who have come out of addiction, out of problematic substance use and abuse, and who will attribute their recovery to having turned to traditional practices, traditional spirituality. And so one program that I was very privileged to be involved in was an invitation by the Detroit Urban Indian Health Clinic to try to figure out how we could package traditional practices and traditional healing into the health services that they offer for their urban Indian clientele. And what we came up with together was a traditional spirituality curriculum that would help anchor and orient Indian people in the urban environment who had otherwise been cut off from that form of traditional spirituality and those practices to learn in structured class-like format how to pray, how to participate in a sweat lodge, what it means and where it comes from, and why it could be useful to you. So that's an example of a program that we designed and developed together precisely to try harness traditional practices and spirituality for therapeutic benefit to people in a healthcare center. Now, does it work? Well, it would have to be replicated. It would have to be expanded. There would have to be larger sample sizes, from the vantage point of the RCT or robust, rigorous cause and effect evidence. And often that is not going to be very possible with these alternative interventions that we develop in partnership with communities.
Thanks. Joe, another question that is related a little bit to the earlier questions about differing ways in which diverse groups of people who self-identify as American Indians may perceive or have explanatory models to do with mental illness. This question refers to whether you see such differences according to the generations of Indigenous peoples, which I found that very interesting. Do younger people, for example, have a more culturally affiliated explanatory model as compared to their older peers because of the fourth era, for example, that we see a rediscovery of Indigenous pride?
Yes. Yeah, I think there are definite generational differences, and they were quite dramatic based on that 1970s resurgence that happened with Red Power. Prior to then, I would say a lot of Native people were not all that enamored of traditions and cultural practices of the past. And, we're trying to make a go of things within modern American life. And that generation that came of age during the Red Power movement, like Traveling Thunder, have a really different sensibility, a very different orientation, one that often rejects Christianity and other aspects of mainstream America, and is pursuing and looking back and reclaiming traditions. And I think that those generational differences are unfolding now within that sort of atmosphere, but they're going to be differential access, differential regard for, differential making sense of what all that might mean for you. So young people today, I think, are much more tuned into, aware of, and have the benefit of generations of people practicing those things. And yet at the same time, they're also contending with, social media and all the other things that have changed what it means to be a human on the planet in ways that have kind of untold, unpredictable, or unclear implications for what it means to live a traditional life. So tradition is always being updated for the modern moment to solve problems, to adapt to changes. And that's what our younger generations will do. And tradition will take on a different form than that which I've been exposed to, or that which my grandmother considered to be traditional, for example.
Yeah. Well, Joe, thank you for speaking, in just such a thought-provoking session. And before we end, I wanted to give you one last question, also an opportunity for any closing remarks. And my question is this: as you know, there is a crisis for mental health care around the world. And this is not only true of Native American people. This is also true of, for example, the mainstream in the United States, where in spite of all the money we're spending on mental health care, on mental health science, every single metric related to population mental health has only worsened in the last 2 decades. I wondered whether your alternative science may have relevance not just to minoritized populations, but also to the majority. And I wanted to hear your thoughts on that.
Yeah, I think there's something to be said for what Traveling Thunder identified as the anomie, which is, as he put it, a loss of identity, a loss of belonging, a loss of a sense of purpose, who you are, what you're supposed to do, how you're supposed to live. And modernity has presented humanity with that for a century and a half, at least, in which it becomes harder and requires greater effort and more ingenuity. It becomes sort of your individual responsibility to create a meaningful life in the midst of the collapse of major narratives about what living a good life should be or how it looks. And so all of humanity is increasingly confronted with the impetus to make your own meaning and to figure out how to live when the shared, the communal, the cultural starts to fade or become less emphasized, or we become more individualist. And so I think there's a lot going on with that is accounting for this. And I do think figuring out how to rebuild community, and that's which is shared and supportive, that which is cultural preserving or reimagining tradition for the modern moment, all can be very helpful and beneficial with regard to the well-being of modern humanity. So I think that is a lesson of Indian country. It might look different in different contexts. It certainly will look different in different contexts, but at least there's an instance here that illustrates one way that can be done.
Thank you, Joe. I think your ideas, your observations actually speak to principles that I hear many people in the global South also expressing about the mismatch between the paradigms promoted by biomedical mental health sciences and those that are extant in their own communities from times immemorial. I see a lot more parallel actually between your description and that of global mental health than might be immediately apparent. And it has very much to do with the misalignment between biomedical psychiatry and psychology and traditional ways of viewing mental health. Thank you so much for provoking us to think in that direction. Thank you also to the virtual audience for your engagement with this seminar. I'd like to remind you all that the session has been recorded and will be available on the HGHI website very soon. Thank you all again and have a wonderful rest of your day. Bye-bye.
So long, everyone. Bye-bye.